Quite an audience here. I think I should take a picture and send it to my kids. Okay, it's a pleasure to see you all here, and this will not go on for a very long time, but I'm going to talk about the four major types of arthritis and just give you some background, and then we'll take some questions at the end. First, just a list of acknowledgments of the various people who've supported the program. You've just heard from Anne up here, and the other members of the committee are on here. So just to give you an idea of the background of the people supporting the program. So there are four major types of arthritis. The first one I'm going to talk about is rheumatoid arthritis. The second, osteoarthritis, which probably everybody in the room has to some degree. Spondyloarthritis, which we used to call ankylosing spondylitis, a type of arthritis not well known to the public, but very prominent in the population. And lastly, gout, which primarily affects men, but you do see it in women, particularly postmenopausal women. So I loved taking pictures in practice, and these are some examples of rheumatoid arthritis. So on your left is early rheumatoid arthritis showing swelling in individual joints that you can see here. I think this is all very obvious to people looking at that. That's what early rheumatoid arthritis looks like. There's an old expression in rheumatology that the hands are the calling card of rheumatoid arthritis. So I would say 85 to 90% of our patients present with swelling in the hands and feet. So that's the typical beginning of rheumatoid arthritis. Now, if the disease goes relatively untreated or poorly responsive, you very often wind up with this type of a picture where the fingers deviate to the right and to the left and form what we call ulnar deviation. And this is a very advanced case. I remember this patient very, very well, had very advanced disease and had a lot of complications of her rheumatoid arthritis. So the common signs and symptoms are morning stiffness, swelling and inflammation of the hands and feet, and commonly and very remarkably, the disease tends to be symmetrical. So you tend to get the right and the left hands looking the same. That raises an interesting question. Can you have unilateral rheumatoid arthritis? The answer is yes. It happens in an unusual situation. If you have an individual that's had a stroke and one side is completely paralyzed, if they then later on in their life develop rheumatoid arthritis, interestingly enough, it only develops on the side that's not paralyzed. So it illustrates a very important aspect of rheumatoid arthritis, that being that there probably are influences on rheumatoid arthritis that are not commonly known, and they may come from the neurological system. Now, here's the similar situation to ulnar deviation in the hands. You have deviation in the feet. And very commonly, these patients develop collapse of their arches. And the collapse of the arches is usually due to involvement of this tendon right here called the posterior tibial tendon, which becomes inflamed, and sometimes that tendon will break and the foot becomes flat. And so you wind up, when you look at the patient standing in front of you, they look a little bit like a duck. You know, the feet are kind of pointed out that way, and usually very, very flat feet. That's a difficult problem for a lot of people. Now let's talk about where rheumatoid arthritis occurs. So first of all, it occurs in every racial and ethnic population, but there are definitely some differences as to, and I'll show you this, as to where in certain ethnic groups it may be more prominent and some less prominent. So it occurs anywhere between 0.72 and 1% of the US population, and the peak incidence of rheumatoid arthritis is between 35 and 55, and the ratio is more prominent in women than in men. So you see female to male ratio is 2 or 3 to 1. So this is a disease that has a great propensity to women, And the peak incidence is in the major age group for which you have a working population, 35 to 55. So it has a major economic effect on people. And lastly, there is diminished life expectancy between 3 and 10 years, and the majority of those deaths are cardiovascular deaths. So having rheumatoid arthritis increases your risk of heart attack and stroke, a fact that's not well known in the population. Now, what about the prevalence of rheumatoid arthritis throughout the United States, throughout the world, and whatever? This is a lot of information on this slide, but I can make it very easy for you. So let's start out with the fact that in the indigenous populations, the Native American populations of the United States and Canada and Mexico and Central America, there's a higher prevalence of rheumatoid arthritis. For example, in the Haida Indians in Alaska, in the Chippewa Indians in Minnesota, 7% of the women, that's a lot, 7% of the women have rheumatoid arthritis in that tribe. And you can see that it's more prominent in the Yakima tribe in Washington and the Pima Indians in Arizona. So a very high prevalence in the indigenous populations. Now, what about lower prevalence? So the lower prevalence is in China, Saudi Arabia, Japan, Spain, and the Congo. And what's interesting is that in South Africa and Nigeria, if looking at 500 cases, trying to find 500 cases and analyzing them in the year 2000, they found no cases of RA. So in certain populations in Southern Africa, very, very little rheumatoid arthritis. So there are definitely genetic predispositions. So how does this come about? So there are interactions between genes that you inherit from your parents. And if you have those genes and you're not smart enough to avoid smoking, you can get into trouble. So we know that smoking can actually induce rheumatoid arthritis. In fact, the risk is similar to the risk that you get from smoking and getting lung cancer. So if you grow up and you happen to have certain genes, I won't get into the names of all the genes, there's a lot of letters and numbers, but if you have these genes, you have a high risk, if you smoke, of getting rheumatoid arthritis. And there's an increase of rheumatoid arthritis in male smokers over female smokers. And the duration of smoking increases the risk. So believe it or not, that's one of the main things that we tell patients. If they come to the office and they tell me that they're smoking, I tell them, well, if you want to get better, the first thing you better do is quit smoking. Now, how did we find out about this smoking thing? So we found out with a blood test called anti-CCP. That blood test, believe it or not, that blood test is, in a way, induced by smoking. So people who smoke can induce this particular antibody. This antibody is not present in normal people. This antibody is completely induced by certain things, and the most prominent thing that induces it is smoking. And when you have, if your doctor looks at you and says, I think you have rheumatoid arthritis, and they get back a positive anti-CCP antibody, you have certified rheumatoid arthritis. In fact, if you have no joint symptoms, and for some reason or other your doctor happened to order an anti-CCP antibody, and you came out as a positive, there's a high probability that within 3 to 4 years, you will develop rheumatoid arthritis. So the anti-CCP antibody has become a certification almost of having either the risk, a high risk of rheumatoid arthritis, or rheumatoid arthritis actually existing at the time you examine the patient. Now, you may want to know why I have pictures up here of gingivitis of the gums. So this is another amazing discovery that happened over, I'd say, the last 10 to 15 years. And that is For people who have chronic gingivitis, pyorrhea of the gums, that condition induces the development of anti-CCP. So the infections in your gum produce an immunological reaction that produces that antibody and then produces rheumatoid arthritis. So actually now, I will tell you that William Robinson, who's the chairman at Stanford, he frequently advises his rheumatoid patients to go into the dentist about every 6 months and get a deep cleaning to make sure that they are not developing or having persistent gingivitis of the gums. So you can see that there are some things we can do that are somewhat preventive. Now, rheumatoid arthritis not only occurs in your joints, it can also occur elsewhere. And I won't go into all the details of this, but just to point out to you that it can produce this horrible condition in the lungs called fibrosis of the lungs, which can be devastating and can contribute to mortality. It can produce nodules on the skin, subcutaneous nodules, like we have here on an elbow. It can produce inflammation of the eyes. That happens to be a condition we call episcleritis of the eyes. But you can have more serious complications of the eyes. And in fact, a number of our patients that we see, the initial presentation of rheumatoid arthritis is not in the joints, it's in the eyes. So worth remembering. Now, there are many, many medications to treat rheumatoid arthritis, and it's not reasonable to go into all of this, but I will just simply tell you a couple of things. One of the most important medicines that we use is a medicine called methotrexate. That's a drug that's been in use for decades and decades in medicine, mostly as a chemotherapy drug. But when we give it to rheumatoid arthritis, we don't use dosages that are in the chemotherapy range. We use little small dosages of methotrexate, and it's very, very effective. This was found out around 1988, and we're still using it. And it still is effective, and because methotrexate is a generic drug, it's cheap. Okay? Now, we also use some of these other drugs, which I'm not going to go into. We do use steroids or prednisone. I'm sure everybody in this room has heard of prednisone before. We do use it, but we try to use it in the smallest dosages possible. Because if you remember what I started out by telling you, this disease is more common in women. And what do women get when they get into the postmenopause? They get osteoporosis. And if you use prednisone, you're going to increase the risk of those women developing compression fractures in the spine and winding up like you see a lot of older women in the grocery store, bent over the carts, right, as they're shopping. And they don't straighten up. That's how they are. They're all bent over from compression fractures in the spine. So we try to avoid, if we can, corticosteroids. Now, the last time I gave a lecture on this, I pointed out that one of the major advantages of rheumatoid arthritis are so-called biological medications. And one of the people in commenting on the lecture said, what are biological medications? So I added a couple of slides here to tell you what they are. So in 1998, the first biological medication came about. This is an antibody that was developed to fight rheumatoid arthritis. The first one being etanercept was the first biological medication, 1998. So what happened in 1998? Well, I started practice in 1978. So for 20 years, we had pretty average treatments for rheumatoid arthritis. But once this came on board, the whole world changed. So now we not only have this etanercept medication, we probably have another 20 biological medications that are made through genetic engineering at some of the highest level that you can imagine by some of the finest companies in genetic engineering, such as Genentech, which has its main office right outside of San Francisco. So the common biological medications are listed here. I'm not going to go through all the names, but you can see we have lots and lots of biological medications. They are most of the time very, very effective. It's really kind of a small percentage. I'm going to just roughly say maybe 10% of patients that just don't respond to anything. So I would say 90% of medication, 90% of patients respond to something. Now, they may not respond 100%, but they respond, 65, 70, 80%, enough to really function well in society. We now have another group of medications that I never discussed before when I gave this lecture called JAK inhibitors. I won't get into exactly what they are scientifically, but these are some of the most unbelievable advances in medicine that have come along in the last, I'd say, decade or so. So the first one that was developed by Pfizer was tofacitinib. And these medications are amazing because, as opposed to the biological medications, which are given by self-injection or infusion with an IV, these medications are taken orally, and they're very, very effective. Yes, they do have side effects. There are occasionally situations where if an individual has cardiovascular disease, coronary artery disease, you have to be very careful about giving a JAK inhibitor. The JAK inhibitors have also been used in the treatment of certain leukemias and other hematological disorders very effectively, and it's a whole area of medicine that has opened up in the last decade. Now, let's move on to osteoarthritis, a subject that is important for everybody in the room. I'll make a guess that 100% of you have some osteoarthritis, including myself. This is the most common form of arthritis, but a single cause is very, very unlikely. It's most common in the elderly, defined as over 65. Okay, you can define it any way you'd like, but that's generally how it's accepted. It's often asymmetrical. Now, you remember when I talked about rheumatoid arthritis, it's symmetrical. Right and left side are mirror images of each other. Osteoarthritis is not the case. The most common affected joints, many of you have these, are the enlargement of the distal fingers called Heberden's nodes, and the middle finger joint called Bouchard's nodes. And then the next most common thing are the weight-bearing joints, osteoarthritis of the knees, osteoarthritis of the hips, and I'll make a guess that we have some people in the audience that have had a hip or a knee replacement. Now here's the typical Heberden and Bouchard's nodes. This is a Heberden's node. I'm sure you all can recognize this. This is a swelling of the middle finger joint that's called a Bouchard's node. This is very, very, very common. And then here we have osteoarthritis of the knees. And you can see here that this is a more normal knee space on the x-ray, but not this. You can see this is bone on bone. And this is the type of a patient that often winds up having a total knee replacement, which is very, very common. In the United States, there are millions of hip replacements and knee replacements done every day in this country. And it's gotten to the point now where they have special teams at the major hospitals, like the Hospital for Special Surgery and at Cornell Medical Center in Manhattan. They can literally go skin to prosthesis to sewing the skin up in 45 to 50 minutes. And you go home the same day. So the treatments. No medicines are currently available that prevent the progression of osteoarthritis. So all that great stuff I told you about rheumatoid arthritis, we have none of it for osteoarthritis. We have absolutely none of it. So we have the non-steroidal anti-inflammatories like ibuprofen, naproxen, meloxicam. Those are fine drugs. They work okay, but, and it's a big but, there's a lot of toxicity. Upset stomach, ulcer, bleeding, and an increased risk of heart attack and stroke on those drugs. Local injection can be done, local injection of a steroid like methylprednisolone, a steroid. Occasionally, hyaluronic acid is injected. And then topically, and you can buy this in the supermarket, you can put topical capsaicin on top of your Heberdin's node or your Bouchard's node, and you have to put it on for like a week or two. And usually you should put it on with a Q-tip because if you get any of it back in your eye, you're not going to be very happy. It's the same stuff that's in pepper spray. Okay. So the last thing you want to do is like, oh, my Heberdin's node is great, but I can't see. Okay, and this is a total knee prosthesis. You can see what it looks like there. Pretty amazing that you can do that in about 45, 50 minutes. Complications. Post-surgical infections occur in 1% of total hips and 1 to 2% in total knees. Now, what I often tell my patients, sometimes I don't think the surgeons tell the patients, I tell them about this because you never want to have a patient go in and get an operation and not know what the potential complications are. Unfortunately, an infected knee and infected hip is really pretty much kind of a disaster because it's very, very difficult to cure it and to get rid of the infection. And why is that? It's because the bacteria form a slime. I'm going to call it a slime. Over the area of the prosthesis, the bacteria are in this kind of slime. And when you take the infected prosthesis out, there still is some of that slime in there. And when you take antibiotics either orally or intravenously, you just can't get rid of the infection. It's very difficult to get rid of it. I can tell you I've seen many infections in my career, fortunately, many more successes than infections. But it's a rare situation where a patient comes in and says, they took the prosthesis out, they gave me the antibiotics, and I'm cured. It's very rare. A lot of times it goes on forever. Now, the third type of arthritis, spondyloarthritis. This is a type of arthritis that perhaps is more common in males than females, usually young people below the age of 45. Commonly, the onset below the age of 40 is what I wrote there. Less commonly begins in childhood, often insidious, and persists for about 3 months with the stiffness improving with exercise, actually. Where does it begin? Very often begins back here in the sacroiliac joints. And in a young man, let's say somebody who's 18 or 19 years old, they come in and they say, I'm stiff as can be. They usually do this. I'm stiff right here. And if you do a full workup and you do genetic testing, you can find out very often that they have a genetic marker called HLA-B27. That genetic marker was discovered a long time ago now, 1974 at UCLA. And we still use it. We still use it as a marker. It's found on the 6th chromosome. It was also discovered in Great Britain at the same time. There's a high prevalence of HLA-B27 in families that have this condition. So very often you see it in one son and another son, and they come into your office and you say, I want to tell you have this HLA-B27 gene. And then you ask, does your father or mother have back pain? And you often get an answer like this, oh yeah, my father has horrible back pain. He's had 4 back surgeries. Okay, the father probably didn't need the 4 back surgeries because he had ankylosing spondylitis, but nobody ever diagnosed it. So this is very common. It's also common with people who have psoriasis, ulcerative colitis, and Crohn's disease. All are associated with ankylosing spondylitis. Now, this may be hard for you to see, but the sacroiliac joints go right here, and this is very fuzzy looking. It should be very clear, but that's inflammation of the sacroiliac joints. And then you can also get inflammation of tendon attachments. Look at the swelling here in the Achilles tendon on this side compared to the other side. And again, sacroiliitis here, and also fluffiness on the bottom of the heel. Very common, by the way, that people get chronic heel pain and Achilles pain. So how do we treat it? We give non-steroidal anti-inflammatory drugs. We give some of these medicines. But guess what? This is one of those diseases that they borrowed all the therapy from rheumatoid arthritis. So we've got tons of biological drugs that we use for this condition, and they are very, very effective. So that's one of the benefits. We have the effectiveness of the biological drugs for RA and biological drugs for spondylitis. And now the last one, which is gout. So looking again at the audience, I can be assured that there's at least one person that's had gout here. The disorder of the uric acid metabolism is what's resulting in the elevation of uric acid in the serum, leading to crystalline arthritis. And this is one that is much more common in men than in women. So women, you have all your problems that I've mentioned, a lot of them, including the osteoporosis problem, which is very bad in older women. But men get gout. And one of the leading contributors to getting gout is doing too much of this, drinking alcohol. Another contributor is the metabolic syndrome, eating all the wrong things in your diet and being way, way over the appropriate body mass index. Very common. Medications, chronic use of diuretics like the drug furosemide. We see that a lot in people who are on furosemide for congestive heart failure and things of that nature. And so when you use these diuretics, your uric acid level goes up and it increases your risk of gout. And most of the time when we see gout in women, it's postmenopausal women on diuretics. So just be aware of that. And here's a picture of gout. Gout in the toe. Look at that one, gout in the toe. These are the crystals. When you stick the needle into the joint to take the fluid out, you can see the crystals right there. This is interesting because you notice the peeling of the skin. So the inflammation of gout can be so intense that it reproduces a second-degree burn. Okay, that's what that is. That's a second-degree burn. You know where you get a blister when you've burned your finger or something? You get a blister and then the blister peels off, and that's exactly what it looks like, but it also happens in gout in some cases. So I show you that because when I saw that in the office, I said, that's a photography day. Now, sometimes gout looks like rheumatoid arthritis, but you'll notice it's not exactly like rheumatoid arthritis. So I showed you before the swelling of these middle finger joints that you can get in rheumatoid arthritis. But what do you notice? You notice the fact that they're not present on the other side. So there's no symmetry. Right and left sides are not symmetrical. And when you see that, and when you feel this feels very, very hard because there are uric deposits in the joint. So this is gout in a postmenopausal woman on diuretics for congestive heart failure. So that's what it looks like, as opposed to the red toe. So the treatment for gout includes the anti-inflammatories, a drug called colchicine. Occasionally we give prednisone or a local steroid injection. And then you have to treat the elevated uric acid with various drugs to try to get it down to a normal level around 5 or 6. And the drugs that we use most commonly are allopurinol and febuxostat, pegloticases in very, very severe cases. And you modify your lifestyle, your diet, and you stop drinking alcohol. That's very helpful. And you manage the risk factors of cardiovascular disease and chronic kidney disease, which are very, very common, particularly in overweight men or even normal weight men who have gout. Very commonly, they have some degree of chronic kidney disease, some degree of atherosclerotic cardiovascular disease. So you have to manage all of those. So that is my last slide, except here's one of our local sea otters that has a headache from my lecture. And that's it. So I'll be happy to take questions. All right. Go ahead, Susan. Well, come up for a minute. I'll just show one thing on you.
But there are so many.
There are many,
Only
but
one.
I never took care of her, but we're good friends. So let me have your other hand. So you can see that she has symmetrical arthritis in the fingers, right? And she has that ulnar deviation. This is the ulnar bone. So the fingers are deviating that way. Very, very symmetrical.
Now, interestingly, I was diagnosed 21 years ago. I was almost immediately put on one of the biologics, and I had no ulnar drift for 12 years. At year 12, I got a pulmonary infection. Oh, by the way, I had lung involvement right away. So I had the fibrosing lung disease that we talked about. But at year 12, I got a lung infection and had to be taken off of the biologics. This happened within a year. I had to be off of it for 2 years. Within that time frame, my hands turned. So do those biologics work? Yes, they do. Now I'm back on a biologic, but you can't undo this. Both of my feet have been surgically corrected at Stanford because my feet did exactly the same thing. So that was actually before my hands, and I couldn't walk or did it with my foot in a shoe. And it was very, very painful. I've been on almost every drug that Dr. Miller put up there. I long-term use of prednisone. I have osteoporosis, compression fractures. Obviously, now I'm on oxygen because of my lung disease. What else? Let's see.
That's it.
That's enough.
Susan is really a remarkable case, but an illustration of how we really don't know why many of our patients with rheumatoid arthritis are fairly easy to treat. You put them on a drug like etanercept or adalimumab, two of the commonly used biological drugs. They get remarkably better. They look wonderful. They don't get infections. They don't get the lung disease. They don't get a lot of those problems, and they do fine. But then you have patients, unfortunately, like Susan, that one thing leads to another. You start with the joints, then you get the lung, then you get the compression fractures and all of that. So she's done remarkably well over the years. A lot of it is genetic, okay? I mean, you have certain things that you are predisposed to get. For example, in rheumatoid arthritis, if you have a certain genetic marker, I don't want to get into all the letters and numbers, but if you have that, you're going to have a higher risk of developing rheumatoid arthritis. But sometimes that risk, it might be you have a 50 times the normal population of getting it, and other times it's just a very small fraction. The thing is, with rheumatoid arthritis, we know certain things to avoid, right, which I mentioned. You want to have absolutely great dental hygiene, right? And you don't want to smoke. If you don't smoke and you have great dental hygiene, you may be able to lower your risk, okay? I'll also mention, by the way, that the dental hygiene thing is not just for us in rheumatology. Talk to the cardiologists about that. The cardiologists will tell you that it's very, very important that you have pristine dental hygiene. One of the things I do and have done for a zillion years, I use a rubber pick after I brush with a mechanical, a motorized brush, and floss every single night. I don't think I've missed a night now in a zillion years. But very, very important that you have good dental hygiene. Yeah.
Minimal to do. So anyway, I'm wondering about the biologics.
So you're talking about osteoarthritis. Yeah. So the question is about osteoarthritis and, have biologicals been tried? Well, you know what scientists do all the time. If something works in RA, they try it in osteoarthritis. Yes, there have been many trials of biologics in osteoarthritis. They've all pretty much failed. Okay. Uh, the um, the advice that of well, maybe you get your thumb joint replaced and all of that. Look, I've been involved in rheumatology now probably close to 50 years. Um, I can't even remember telling somebody that. In general.